Welcome to the battle of the night. The topic of this battle is the surgical challenge in full arch reconstructions in patients with extremely resorbed jaws. And I have here with me Professor Henning Schliephaker. Henning, good evening.
Good evening, Garrett.
Good to be
good
back together again. Yes, you are the past president of the EEO and you're also an oral maxillofacial, that word, I love it, surgeon at the University of the Hospital in Göttingen, Germany. Tell me, Henning, why is this group of patients so challenging and what are we talking about tonight?
Well, good evening, dear colleagues. This challenge is easily defined because if we want to place implants, we need bone for reliable osseointegration. And in these patients where you have a severely resorbed maxilla, the bone that we usually use to place implants, the alveolar ridge, is gone. So these patients, these people have to undergo additional or modified procedures that definitely increases treatment burden. So let me show you a case. You see here a severely resorbed maxilla. You can already see the cartilage of the nasal septum, so the premaxilla is completely gone, and all what's left are little tiny remnants of the palatal bones on both sides of the jaw. So if we want to restore the alveolar ridge, we need huge volumes of bone. And large volume bone grafts cannot be procured from the intraoral site. We have to go to extraoral sites. So one of the most commonly used extraoral sites is the anterior ridge, the anterior part of the alveolar, of the hip,
right?
Yes,
that's what we're looking for.
of the crest, of the iliac crest, and you see these bone grafts that we can procure have adequate volume. They are corticocancellous bone grafts, and when you fix them to the jaw, you can see that they can adequately restore the ridge of this severely resorbed maxilla. The downside of this approach is definitely that these procedures are so extensive that we have to take the patients to hospital, which increases their treatment burden considerably. And secondly, when you take bone grafts from the iliac crest, they may undergo or they may suffer significant donor site morbidity. And you see such a patient with a fractured right iliac wing after extensive harvesting of bone for mandibular reconstruction. Admittedly, we do not take that much bone for pre-prosthetic reconstructive surgical purposes, but these patients still can suffer pain, can suffer gait problems, limping, all these problems that have been described for and associated with surgical harvesting of iliac crest bone. So now an alternative approach is that departs from the reconstruction of the alveolar crest and simply uses what is there, saying forget about augmentation, use the bone that is there. And this is the zygomatic area that is very stable even in resorbed ridges, and the remnants of the maxillary bone between the nasal cavity and the sinus cavities. But if you look at the procedures that you need to use to place these implants, they are everything else than minimally invasive. You need a bilateral sinus lift, you need large burrs to place these implants, you need an extensive dissection of the zygoma. You see in order to be able to control the implant position, you see the little yellow circle that marks the implant edge. So when you are finished with this procedure, you have an extensive dissection, you have a complete exposure of the maxilla, higher up even than the orbital floor, and this is definitely associated with significant treatment burden. So we have these both concepts on the table, and we will battle these concepts and we will discuss them. But maybe let's first see what the audience prefers.
Exactly.
Garrett.
Please, we want you in the mix. So we have launched a vote. What would you do if you had a patient with extreme maxillary atrophy? What procedure would you recommend to this patient for implant-supported restoration? Would you go for extensive bone grafting with implant placement? Would you go for these zygoma implants? Or perhaps you don't know yet? Now, to participate with your vote, all you have to do is grab your phone and scan the QR code available both to you on the screen right now, or if you miss it, right below the live stream player, you'll see it also. You'll be redirected to our secure Slido website where you can easily cast your vote. What is your option out of the three? Now, while you're voting, let's welcome our two experts on the matter, Dennis Rohner from Switzerland and Hendrik Terheyden from Germany. Good evening, gentlemen.
Good evening, guys.
You look excited.
Yeah.
Henning, who did you bring along to explain us all about this?
Well, On my left, it's Hendrik Terheyden. Hendrik is an oral maxillofacial surgeon. He is director of the Department of Oral Maxillofacial Surgery at the Red Cross Hospital in Kassel, Germany. One of his major focus areas in research and clinical interest is pre-prosthetic reconstructive surgery, and he's a real expert in reconstruction of the alveolar ridge. He is published widely and lectured widely nationally and internationally. On my right-hand side, it's Dennis Rohner. Dennis is senior consultant and co-director of the Craniofacial Center in Aarau in Switzerland, where he has served for almost 18 years now. Dennis became well known for using fibula-free grafts for the reconstruction of severely atrophic and deficient jaws, but has adopted a strategy of using 4 zygoma implants now to provide full arch restorations in these poor patients. So we have 2 experts in 2 different opposing fields, and we will watch the battle, and we will give you both 5 minutes each to make your points.
Yeah, and I think it's important to point out, this is not really a battle of right and wrong. Eh? These are 2 different approaches for similar cases, and the challenge actually is we gave you 5 minutes to clarify as much as you can, and then we talk about it together. So, Hendrik, I think we invite you to start.
Thank you, Gerrit. Let me tell it like this. Alveolar bone and fixed gingival tissues are tooth-dependent tissues, and they fade away once the tooths are gone. But my point is, this is not irreversible. In an atrophic maxilla, we can resect a little bone to create room for a bulky prosthesis, cantilevered prosthesis, a very stable one, but we also, in contrast to this, have a biologic regenerative protocol where we preserve the tissues and integrate tiny, delicate prostheses. In the elderly, we have the task to enable social participation. This involves eating in company, but also to create attachments, functional attachments for the facial muscles, to prevent a sagging chin, inverted lips, hanging moduli. The mandible is treated with a sandwich osteotomy technique, and simply bone substitute material is interposed, and in the maxilla we can do the same. By a level 1 osteotomy, we can downfracture the maxilla and create a frame with little small iliac strips, not so much as our chairman has just shown, and the bulk of the material is bone substitute material covered with membranes. 4 months later, this graft is remodeled, and function during this time is provided by these little provisional implants. And look upon these cephalograms, how much bone was gained vertically. The maxilla was also moved a little bit forward, and this allows us to place the implants parallel, and this enables an easy prosthetic workflow, and no cantilevered prostheses are necessary. This over 70-year-old patient, she stayed with her overdenture concept, locators were used. And look upon this lower face, the lips are prominent, the moduli are staying upwards, and there's no sagging chin. The fixed gingival tissues have reappeared without any soft tissue grafting, just bone grafting, and also in the mandible you can see the difference. The crest emerged again, and food strips off, and this becomes self-cleaning. The 5 and 10-year follow-up shows that it is a sustainable rehabilitation. And although this patient is over 70-year-old, she can bite an apple and is self-confident to visit a public restaurant. Sustainability means cleanability. This atrophic maxilla was also treated with the level 1 interpositional grafting using iliac crest and bone substitute material. The implants stand parallel as a sign of a good bone augmentation. And again, the fixed gingival tissues have reappeared. The atrophy has been reversed. A cantilever-free and therefore tiny and delicate prosthesis could be integrated. And look how nicely these implant posts can be cleaned. if one concentrates on function and bring back the function, aesthetic will simply fall into our laps. We have recently submitted a 10-year evaluation of 106 patients with this level-1 interpositional grafting in the maxilla. And as you can see, the implant survival after 5 years and after 10 years was higher than 95%. An old objection against jaw augmentation is bone resorption. Indeed, we see here in the beginning, in the blue phase, a little bit of a bone resorption, but after the implants have been integrated, the red curve, the bone stayed stable, and over 5 years there was only 0.25 millimeter. So I have to say this bone again became a tooth-dependent tissue preserved by the occlusal function of the dental implants. So the atrophy has been reversed, and I think with the right surgical technique, these tissues can reappear, and we have the option to turn back the biological clock. Thank you.
Beautiful. That's even exactly 5 minutes to introduce us into the topic. Very well shown case, well documented, and even backed up with science. That's impressive, Henning.
Definitely.
Right? From an educational standpoint.
Yeah,
well done,
Henning. Yes.
Yes. It's also impressive from a content standpoint.
Clinical point.
It's difficult, yes, right, to bring it in 5 minutes altogether. So, Dennis, there's an alternative approach for these jaws. Could you tell us what does it look like if we choose the zygomatic implants?
Yes, of course, I will tell that. So I'll tell you first that zygoma implants are just great. So we used them in the past for tumor patients. We had to resect parts of the maxilla and inserted zygoma implants and could support them with prosthetics, and it worked in the long term. So that's why we also used these implants also for the atrophic cases. And since we could see that it was just great, and it was just in 1 day done, so we said, okay, life is too short just to waste it. So we just wanted to improve the quality of our life of the patients, and that's why we have a new option, another option. And based on that, if you look, or maybe I ask you 4 questions or a few questions. What is, how can we do a stable chair? We need four chair legs. How can we fixate a prosthetic on 4 implants? We need 4 stable implants. And if we do not have enough bone, we just go and look for more bone, and more bone can be found in the zygomatic area. So there we have certainly enough bone to place zygoma implants. And if you can place the zygoma implants within the area there, then we can place 4 zygoma implants to support a fixed bridge. So that was the concept of our new option treatment. So we have just 4 implants to insert. We have no bone augmentation. We have just 1 surgery to be done, immediate function, 1-day rehabilitation, and that's why the patient acceptance is quite high. And if you look now at the layout of the 4 implants, the layout is in a quadrangular layout so that we have a good prosthetic support of the bridge. The technician can produce a fixed bridge, fixed on the 4 implants. We have no limitation of the oral palatal oral cavity, and we see that also in the vertical height we have a good aesthetics and good function. And if you now look at the postoperative radiographic X-ray, we see the concept of the 4 stable implants supporting a bridge. So there are basically 2 surgical techniques. In both techniques we are using an extensive sinus lift procedure. We push the bone inside. We place the zygoma implants exosinus but intracrestal in one technique. And if we do not have enough bone on the lateral side, we just place the implants exosinus but also extracrestal, and we cover it with a Bichat fat pad just to have a long-term stability of the soft tissues. So we want to have a safe and stable technique, and we have a safe technique because the sinus is free. We are out of the maxillary sinus, and we are stable because we have a good anchorage in the zygoma. And this means that we always provide the patient with a temporary bridge immediately after the surgery. We keep the bridge for about 6 months, and then the technician will produce the final bridge, and we have a good aesthetics and good function. So you will certainly find enough publications in the literature. They will show you that the long-term results show high success rates. We have just as advantage just one single surgery. We have immediate rehabilitation for the patient. We have low morbidity, no donor side morbidity. It's outpatient treatment. And of course, I can combine the zygoma implants with the standard implants, no problem. And we have quite reasonable costs for the entire treatment. And that was the reason that I told you at the beginning, zygoma implants are quite fantastic, because we can have a treatment of an atrophic maxilla with 4 zygoma implants as an elegant treatment. And that, I guess, this is my votation for the zygoma implants.
Beautiful. You even have 50 seconds left, Dennis. That is an education in 4 minutes.
Yes.
Even. Very clear. Thank you very much. Shall we quickly check what the
That's
audience
a good idea.
voted?
Yes.
Because there's quite a lot of people who are voting already. If you're just joining us and you still want to cast your vote, you can still scan the QR code on the bottom of the live stream player. And we see here actually that our audience is relatively divided. We have a good 2/3 majority who actually says, well, I would go for extensive bone grafting with implant placement. Hendrik is getting really happy. We told each other it's not really a fight, Hendrik, but now you're celebrating. We see 1/5 of the audience going for the zygoma implants, and also a good portion saying, well, I don't know yet. So this is a fertile grounds for education here tonight. Henning.
So let's see where these 12% move to.
Exactly.
Well, guys, I mean, as Gerd said, it's not going to be a battle like it's the one-size-fits-all thing. It's more or less that we try to develop which case would need this or that measure. So the first question that goes to both of you, first to Hendrik, the case I showed with this completely resorbed premaxilla and this brittle palatal bones, if you use the LEFO1 approach with a down fracture, it will probably fall to pieces. So how would you solve that case with your technical approach?
So I would say every technique has its place, and as you said, this is nothing for the interpositional grafting. Let us not forget the subperiosteal printed patient-specific implants, which are anchored in the zygoma, and nasal buttresses, which do not undergo atrophy. Let us not forget fibula case or fibula flaps, especially for the oncology case. This was almost an oncology case. No? And then let us try to put also the zygomatic implants into the game. Yes.
So Dennis, would that be a case for your approach?
It depends a little bit on the situation of the patient, of course. Yeah. So if the patient is 60 or even younger, so then I would even go with the fibula case. So that means that I would try to reconstruct the height and the width of the alveolar crest with a free fibula graft. But of course, you can also start to combine these cases. So let's say that we can try to find some bone in some areas and place 3 zygoma implants and 1 standard implant, or 2 zygoma implants and 2 standard implants. So it's all about preoperative planning as well. So we didn't speak about that. So in all the cases that we are doing, we just have a CT scan, and then we insert it into a software, and then we try to plan and play around and see where is bone, where is enough bone, where do we need some bone. And I guess at the end, in discussion with the patient, then we decide what to do.
Of course, it's a joint decision making. You have to include the patient's opinion. But would then zygoma implants be an option for the frail patient, the patient that is unfit for major surgery?
Yes, of course, yeah. Because still, so if you look at these patients that are not fit or very old, so the surgery takes us about 2.5 hours as an outpatient treatment in general anesthesia, which is quite acceptable for all for these old people as well. So, I mean, this is one option just to bring them back to a better quality of life.
Yeah. Okay.
Shall we take a quick audience question
Yes,
as well?
yes, yes.
Paul Sarah is writing us on the live chat that in terms of the amount of complications and morbidity for the patient, what can the speaker say about comparing these two techniques? You referenced it a little bit already.
Yeah.
2.5 hour surgery, even fragile patients can take it. Can we go deeper into that?
Yeah, maybe that's a question that
I would
challenging
say,
for Hendrik.
I would say in every intraoral surgery, you have a certain amount of wound dehiscences, and it is in my study about 10–12%. But there were no major complications. There were 2 cases of complete graft loss, I have to say, among these 106, but the rest, 104, had no major complications, yes. No loss of sensibility and so on.
And problems with the iliac crest?
From time to time. In osteoporostic patients, we can have a marginal fracture, but this usually heals with using crouches. The patients usually don't use crouches when they leave the hospital after 3 to 5 days. So we can reduce the amount of bone. And I think the complications are dependent on the amount.
Yes.
And we can reduce it to a very little incision and little amount, yes.
Dennis?
One of the main complications, especially in the past, was certainly the infection of the maxillary sinus. And that was the reason because we just went through the sinus in the first time. But nowadays, when we are doing it out of the sinus, outside of the sinus, so this complication is very rare. Yeah. If there is a complication of infection of the maxillary sinus, we just need the ENT surgeons just to open the lateral nasal wall, just to have a better outflow of the infected sinus, and then it's gone as well.
Okay. So we have the results of the second vote, so maybe...
Well, this is still the result of the same vote, Henning, that we are looking at.
It has changed a little bit.
It changed a little bit. The don't knows have moved to a choice, and they looks like they're even moving more into the extensive bone grafting. I'm still a bit curious because I hear a 2.5 hour surgery versus 3 to 5 days in the hospital. And of course, sometimes that's needed. But is there any case where you would say, Hendrik, I would go definitely for zygoma, or vice versa, where you would say, now I would recommend my patient to go for bone remodeling?
I would say that in younger patients, I would certainly go for bone reconstructions. And in older patients, I would certainly go for zygoma implants. That's what I can say.
Health is also an issue. A patient has to be fit for surgery.
Yeah, right.
And
right.
This is clearly the case for the lower invasiveness of the zygomatic implants. Yeah.
And then it's when you say age, has that also to do with the durability of the solution, perhaps? Is there a risk involved that maybe after 40 years the zygomatic implants become a problem?
Of course, we don't
know yet. We don't have the data.
These long-term data, we have the data about 10, 15 years, but not longer. But so I still believe so. If the implant is stable in 10 years or in 50 years, then it will be also stable in 20 years and 25 years. But we have to wait for the results.
Yeah.
Well, Hendrik, I mean, with the LIFO1 approach, you normally routinely would open up the sinus. How do you handle sinus mucosal lacerations, lacerations of the nasal floor? Because you work with particulate materials that would spill into the sinus, and then of course
very simply you do a sinus lift preparation dissection before. Yes, it is close to the sinus cavity. Yeah.
So, but you need to be careful to not to.
In case you have a laceration, you can try to suture, put a membrane, PRF membrane, and so on. Of course, this happens, but it is intended to leave this intact.
Okay. And
Henning, shall we take one more? Because we're checking off all these different... we age, health.
Yeah.
What about later in the treatment phase? From the prosthetic point of view, is there any limitations for each of the approaches? Is a question from João Rodrigues.
Difficult to say. So at the end, of course, the prosthetic part is something that has to be done in cooperation with the prosthodontist. Me, as a maxillofacial surgeon, I'm doing more or less the surgical part. But of course, before we do the entire surgery, we have a kind of planning and an outcome, and we can say, okay, this would be the prosthetic outcome of the patient with lip support and the length of the teeth and so on. So at the end, I guess we can more or less reconstruct more or less everything with the prosthetic.
No limitations.
Prosthetic device, yeah.
But that's what people say sometimes, that where the implants enter the palate on the palatal side, that's unfortunate for the prosthodontic reconstruction, limiting the space for the tongue, phonetic problems, cleansability problems.
Exactly.
How do you tackle these problems?
Hendrik?
Let me just add, we have to distinguish whether we have a fixed screwed prosthesis or we have removable.
Yeah.
If we have fixed prosthesis, then we have to hide the transition line between prosthesis and gums behind the lip. And this is clearly a static limitation. This requires bone resection and so on. With the Liver One approach, you can let emerge the crowns from the natural gingiva. That is a big chance. So there's a difference between both approaches.
Dennis is nodding.
Yeah.
Anything else we need to take care of, or can we go to a first conclusion? I mean, this is super fast pace. We had 5 great minutes of education from both sides. Good discussion, good audience questions. Henning, what are the most important things we write down in our notebook tonight?
Well, I think, like always in life, it's not white and black. It's gray in a way. We have seen that you can achieve adequate restoration with both techniques. Both techniques have their pros and cons, their weaknesses and strengths. And I think it's a little bit up to the discussion with the patient, which way you want to go. It's a little bit up to the medical condition that the patient is in. So both are available, and you should at least know about both of them, and you will probably develop your own preference in your own office.
Exactly. In the end, it can also come down to personal preference.
Yeah.
Beautifully. Thank you so much, Dennis, for taking the opportunity to share this with us. Hendrik, thank you so much. And Henning, it was great to have you back on my side here, the only time tonight.
But yes.
Good to see you. Thank you so much. This was the final battle, which was really up to standard to what we have seen from the colleagues in the other nights. I'm sure the audience has enjoyed it as we did. Thanks again. This was our Battle of the Night.